Before we begin and jump into our agenda, just wanted to remind everybody of a few housekeeping rules or items. So first, if everybody could just mute themselves, and you can see sort of the toolbar there, sort of in the lower middle part of your screen. If you could just hit your mute button. We definitely want this to be interactive, and so I'm going to be monitoring the chat function. So if you have a question or a comment, please put it in the chat, and then when we actually get to some live Q&A, if you want to raise your hand, we will get you to be able to speak to our speakers. And then if for some reason you need to leave, there's the exit webinar button. So, Mary Jo, next slide, please. We have a pretty full agenda this morning. As we always do, we're going to start with an update from Dean Falak on sort of what's going on in the college as well as UC Health. And then we're going to be very privileged to get an update from Dustin Calhoun on the COVID vaccine rollout for the college and UC Health. Hopefully most of you, if not all of you, have at least had the opportunity to get your first dose. I get my second dose next Wednesday, so I'm very excited. And as we continue to sort of roll out through the state and the region. And then just kind of rounding out our agenda, then we're going to have a discussion. Oftentimes we have the first and second year Medical Student Association reps come and speak. This time we are actually having two fourth year students that are going to give a brief presentation. They are wrapping up their interview season, and we thought it would be really interesting and insightful for them to share their experiences on doing virtual residency interviews and sort of let you know how that's going. And then we'll, of course, have an update from the team from Mary Jo and Kim and Gabe. So again, if you have questions, please enter them in the chat function. And then when we get to the Q&A, hit the raise your hand and we will call on you. And with that, it's my pleasure to introduce Dean Falak, who's going to give us an update from the College of Medicine. Andy?
Thanks, Chris. Really appreciate it. And I really appreciate your leadership of the Alumni Council. And as I stated a few times, I think we want to give you this position for life. To do that, really appreciate everything that you do and the time and effort that you put into things. And I actually follow you on Twitter, so I keep up with you on Twitter also with things like that. Talk about a few things here. One topic that I usually talk about is give a little bit of a COVID update, but you're going to hear from Dustin a little bit later from that. Just to give one quick update, from the university and the college's perspective is that we are testing all the students upon arrival, and our students, the medical students, are all back. And we actually have had a 1.7% positive rate of UC students, and this is all students coming back, which is absolutely phenomenal. Our county's in the gray zone, in the purple zone, which means it's more than 15%. And to have that from the students at all levels coming back is really great to see that some people are taking this very seriously and following that, which is good. So our clinical students are back. We're really maintaining them in their clinical rotations. The world has changed for them, and you'll hear from our students. They will talk about their experience. But one of the things that we're working on right now is also the match day celebration and honors day graduation. And unfortunately, those are going to be different again this year. I don't think even by our May honors day date, we're going to be able to have large crowds of 300, 400, 500 people in a room celebrating. So we're working on how to make virtual experiences for them that are meaningful this year, and some combination of those. So I feel bad for the students because their world has really changed a lot, and we miss that personal contact with them. And we don't even recognize them anymore because even when we see them in the building, they always have masks on. So it is a difficult process for that. The other aspect is, and this is one thing that we're really, really grateful to UC Health for, was when UC Health put in their numbers for the vaccines that they requested, they actually included students as part of the workforce. So they got vaccines in, and we were able to offer all of our students who wanted a vaccine. And that's unusual. Some schools have done that. There are indeed some, but there are a lot of schools where students fell into the gray zone of, where are we going to get the vaccine for them? They weren't included in that process. So Dustin, when you hear from Dustin, thank him for advocating and actually providing the vaccine for our students, because he coordinated that whole process for doing that. Few things that are going on, and please, don't hesitate to interrupt with questions or anything. I prefer dialogue. It's a little bit harder when we're on a flat screen than we're face to face in the room. But a few leadership changes that are going on in the College of Medicine. We are in the process of recruiting a new chair for the Department of Internal Medicine. We're down to final candidates, and starting to hopefully bring that to an end within the next several weeks or so for internal medicine. We're going to be starting a search for a new chair for our Department of Environmental and Public Health Sciences. As you might recall, we changed the name of that department last year to include public health in that, and that search will be underway. Glenn Talaska, Dr. Talaska has done a great job as the interim leader, and he'll stay on until we recruit a new one. We're hoping that by next fall, we might have a new chair of that department. That department also is the home for our MPH program, which is growing, and we are working on putting together a combined 5-year MD MPH program, which will save the students some time and money in having the combined degree program like that. And we are also in the process of starting an undergraduate public health degree. And a minor will be starting in that in this fall. And then pretty soon thereafter, we hope to start a major in public health. And we think that'll be a good addition to the college and to the university also. It is actually involving 9 different colleges in that degree. So it's really, really good. And the last one is the Department of Otolaryngology, Head and Neck Surgery. Miles Pinzek has been the chair of that department for 15 plus years. Miles also serves as the CEO of UC Physicians, our faculty practice plan. Miles will be stepping down from both of those positions at the end of June. He will be staying on the faculty, but Miles has been, he's been at UC almost as long as I have, and that's been 43 years. I've known Miles for a long time. So that'll be a big change. And we are, in all likelihood, going to be doing an internal search because we have a really, really strong department of otolaryngology. And I can tell you that with the internal medicine search, it is really difficult to search and to hire a new chair for a department when you have trouble bringing them onto campus and flying things like that for them to get to see the place. And when all the interviews are done by Zoom and by Skype and things like that. In some ways, it works well because they got to see more people, but it's just not the same as seeing people in reality. On the real positive side, last year was a great year for research at the College of Medicine. And we had over $135 million worth of grant holdings and $104 million of grant expenditures. We were challenged to increase our grant holdings by 25%, and we did it by much more than 25%. We went from the low hundreds to 135 million. So it was really, really, really great. Our faculty are doing a great job. We had 605 submissions and 218 new grants that were received, and our faculty had a funding hit rate of 36%, which is really, really good. That means a third of all grants that they submitted were actually funded in a very, very competitive market. So kudos to our faculty researchers who have really been hitting the mark. And we're 60 to 65% of the research for the university. And as you all know, we're a Carnegie One research university. Somebody popped a question in, so I'll divert to that about the interim chair of surgery for that. Jeff Sussman is doing a great job as the interim chair of surgery. The plan that we have is that We will, after we do the public health one, I'm thinking that it may be around this time next year that we can start a search for the new chair of surgery. We want to get the medicine one on board, public health. There's only so many, we only have the bandwidth and the financial resources to do so many, at a time. And, very comfortable with Jeff Sussman and his leadership, but we know that that is the next big search that we need to do for surgery like that. So I appreciate the question. Another big initiative that we have is a program called Advancing Inclusion in Medical Education. And this is an initiative that is being led right now by Lisa Kelly, who's one of our faculty in ophthalmology, and Tracy Pritchard, who is in the Office of Medical Education. And what this is to address the inequities based on race and ethnicity, gender, and disadvantaged status in the medical school curriculum. So this is a program, and they have, I think, 5 different subcommittees that is really going to be looking at the medical school curriculum in particular, and look at how we train future physicians to be able to treat a diverse population with cultural sensitivity, to support the professional development of students from demographics that are underrepresented in medicine, and create an environment that embraces having a multicultural work and learning environment. There are a lot of things that we have implicit biases in our curriculum. There is discussion about when you do a presentation. When I learned, you always gave the sex, the gender, and the race of the patient. Is that necessary? Is that good or bad? We have to address some of those issues. When we have a model that, in pharm and physiology, I always learned it was, the model that we used, it was a 70-kilogram white male was a standard for everything that we used. And drugs are different in different races and ethnicities, or different enzyme pathways and things. So really to look at all of those things and how we can just extinguish some of these implicit biases, or at least recognize them and know where we're going to make a more inclusive approach to medical education. I think we do a really good job in many ways, but I think there are a lot of ways that we really can move ahead to make sure that our students are prepared to take care of any patient population, regardless of race, ethnicity, gender, or status like that. So this is going to be hopefully by May, they're going to have some preliminary recommendations out. And it's a culture change as much as a content change. So there'll be some content changes plus some culture changes. We do have some occasional flare-ups in the educational programs of people denigrating students and students of fear that they can't speak up because of their status. So we need to work on some of those issues. And I'm really excited about this, and Lisa and Tracy are doing a phenomenal job in this process. The last item I want to mention, and then really be open to questions or wherever you want to go with this, is over the past several months, and stimulated by our Senior Associate Dean for Research, Melanie Cushion, we had a program of gratitude awards that we put together. And this was absolutely, it turned out to be really wonderful. I asked, my cabinet, our Senior Associate Deans, and they funded this, which was, develop these gratitude masks that people would receive as just a little token. And anybody could nominate someone for this award. And I got a lot of pleasure out of it because I got to sign all the certificates and the letters of thanks for them, and the remarkable above and beyond attitude that our people have, attitude and actions that our faculty, staff, and students have had. So we've had to give out close to 150 of these awards to faculty, to staff, to students, and again, based on somebody nominating them for something exceptional that they have done. And the way people, really stepped up in light of the COVID crisis that we're having right now has been absolutely phenomenal and heartwarming. And just, to be able to thank some of the people for the great work that they're doing was just, it's just a pleasure. So I got to spend 5 to 10 minutes a week reading through these and signing these things. It was just, when you get overwhelmed and depressed, we learning a lot more. I'm reading more about the neuroscience of gratitude I now keep a gratitude journal, and every night I write down 3 things that I'm thankful for that given day, because sometimes I get sucked into the morass of problem after problem. We see death, we see despair, we're worried about the crisis occurring, and amidst all of that, when you're surrounded by the great people that we are at the College of Medicine, the great students, the great faculty and staff, it really keeps me going and gives me hope every day. So I just wanted to share that little, story with you about the excitement about these gratitude awards and how important little things like that are to all of us to do things and to do that. That is what I put together as a report for this morning. I'm happy to talk about, other things. I think, you're hearing from the students about their experiences, 4th-year students with virtual interviews, and how they're planning on matching without being able to visit. Some of these may be matching to places where they've never visited the city to do that. So just imagine spending the next 3 to 7 years of your life because they didn't go on interviews. They didn't do away electives. So you'll hear from them about their resilience in adapting to the changes and moving things along like that. So I'm open to Chris, to any questions or comments. As you know, I don't like to give long monologues on things, but if there are topics that people want to hear about, I'm more than happy to address any questions that we have.
Great. Thank you, Andy. Thanks for that update, and thanks for all of your leadership for the college. We've got about 10 minutes for questions. So, if you want to ask Andy a question, John, I see your hand up. Dr. Keith.
Now, I've seen recently some statistics that even though we're in this pandemic, is that the numbers of students are increasing in applications to medical schools across the country. Are we seeing that?
Yes. So, Dustin, I see he's on, he'll talk more about just what the numbers are, as far as the pandemic, but as far as the medical school applications, they are up. Some people are calling it the Fauci effect. Tony Fauci has been a great role model for science and for medicine and things like that. To do that, so it's being called the Fauci effect. But there has been a significant increase in applications. What I will do for the next meeting, I'll have a little bit more data for you, and I'll make sure I bring some of that data to the next meeting. But it is to the point where what we have done this year is they have accommodated more interviews and doing things. The timing is different. It's going to be extending later. For those of you who are on the admissions committee, I think there's some of you here that serve as, raters on the admission committee and things like that. We've extended the process a little bit longer. We started a little bit later to do things. We have great applicants like we always do here. Last year on the admissions process, I was pretty worried because we were oversubscribed. People want to come here. I mean, it's a great, for the school, but we also then, if we have more than 180, we run into all kinds of physical space preceptor limitations. And last year we were over that by 2 or 3 at the end of the year to do that. So the initial acceptances, we're actually giving out fewer initial acceptances because we cut it a little bit too close last year to do that with the fill rate. And so we may need to go into the wait list, but that doesn't mean anything negative. It just means those are very, very qualified people who are on the wait list too to do things. But it's to prevent us from having an oversubscribed class that would create major problems for us logistically to do things.
Andy, what's your number that you're shooting for in this year's class, or this, the class you're interviewing for?
180. 180 is our number.
Okay, great. Thanks, John. Dr. Sawyer, go ahead if you want to unmute, and the floor is yours.
Great. Good morning, everybody. How is everyone? Good. So my question is, I know I sound like a broken record, but now with purple, Hamilton County's purple, and we need to do something different. And one of the issues I'd love to see UC become the first medical school to teach medical students that the eyes are a direct port of entry into the respiratory system. The public does not know that. And as we keep repeating the mask up, covering nose and mouth, eyes are exposed. We're not talking about eye cover. So I would love to see, I know the medical students have face cover or face shields, and I'd love to see them be taught this is a critical piece of equipment to protect themselves and retrain their behavior, because they're going into a high-risk environment in their life and their career, but also it'll help stop self-inoculation, direct inoculation, which is a huge part of this perpetuating the pandemic. So everybody put face shields on. I know they have them, but if they can wear them to show the public, it'd be wonderful. And we could say, go Bearcats or UCCOM. So change of basic behavior for protection. So thoughts on that? I've been trying to get people to do it.
So I'll get just a couple of thoughts on there, Will, and appreciate that. I appreciate what you're saying. One is that in the clinical settings, they're going to mimic what the faculty, what the physicians, nurses do. And I think, putting that on, if everybody else is wearing them, they'll wear them too, to do that, whether you have them or not. I know when I go over to my office and see patients, they all have their face shields or goggles on. In fact, my goggles are sitting here home because the last time I saw patients, I had my goggles on. I forgot I had them on over my glasses. And I must have looked pretty funny walking down the street back to my office with my goggles on like that to do that. But I wasn't, last Friday when I was in, there were some students in because we do have some face-to-face in clinical skills and things. And the students were walking through the halls, at least for that exercise, with their face shields on, doing that. So we're trying to teach them as best we can. But it's like when we teach, I can teach the medical students how to take a blood pressure the correct way, with the patient sitting with their feet on the ground, 5 minutes, relaxing, their arm propped up with an empty bladder and all that kind of stuff, and doing that. And then they go to an office or the hospital, and, the rush is to get things done. So you don't always do it the right way to do that. So I think the more we can all role model that, the more we can enact that and do that. But we are trying to enforce that as best we can in our practice sites to do that.
Well, I actually think it should be in the first year. We give them a white coat, they get a stethoscope and a face shield, because again, it's a critical behavior. And just on Zoom meetings, how many of us touch our facial mucous membranes, risking inoculation? So public health isn't teaching it yet. Let's lead it. Let's let UCCOM lead it. That's my request. Thanks. Okay.
As I say to some people, when I'm on some of these Zoom meetings, in my role, I'm very capable of asking questions if you don't. So if you don't want to be called on, you better keep on asking me questions, or I may call on some of you to answer some questions for me.
I'll make a comment and then I have a question. So I put in, most of you know Will's website, henrythehand.com. I put that in the chat there, and some great resources for your patients. My office actually ordered they were very inexpensive. We ordered some face shields from Will for our staff to use. Andy, you had mentioned the combined MD MPH program that's going to be coming on. Has there been any talk or thought about offering the master's in medical education, that's the joint course between Cincinnati Children's and the College of Education? Has there been any thought about offering that for medical students?
So I don't know if there has been. It's a good thought. What we do is we do have a kind of a track, an elective track in the medical school for some students who are more interested in education. We do have some electives and things like that. We don't have a formal degree. If somebody approached us, I think, we certainly would be able to do that. But I think we can, send a note to Pamela Baker and see if that's, something that they might be able to look at too. We have a couple, options, opportunities. So we have an MD, MBA degree. Basically what they do that in 5 years also, but what they basically is drop out of medical school after the third year, take their MBA, and then come back for their fourth year. So we allow students to do that, take, a year off to get another degree. The MD MPH is going to be more integrated, where, you'll get credit for a course in two different schools, and that's the hardest thing to navigate, at the university, is how you can minimize the time. So you're taking basically a 1.5 to 2 year program, a 4+2 into a 5-year program to do it. So it's some more of that combined like that. And the logistics of those are, if you drop out of one part, you're still in the other. There's a lot of technical things that we have to work through with that. They sound real easy, but they're actually administratively difficult. But I think the MD MPH should be a good selling point. And we actually hope to have that up for some of our current students, probably entering the second year, may want to start that as early as this fall, next fall, in doing that. So we're looking at that. So since nobody else has their hand up, I'm going to pick up on Dr. Knight here for a minute, because Bill has been doing some really good work for us with the Honor Council and taking leadership of the Honor Council. So I just want to, do a shout out to Dr. Knight for his work with that. They've called me to a meeting of the Honor Council so I can, work with them. But Bill has really stepped up and reinvigorated that. They get to deal with some interesting and difficult issues. As you can imagine, we take 180 students in when you have a sea of humanity like that. Sometimes we run into some issues and problems and things like that. And it's just great to have people like Bill who are willing to spend the time and the effort and the energy to coordinate the process and to make sure everybody's treated fairly. So Bill, I don't know if you want to say anything, but I just wanted to give you a shout out and thank you for the great work that you're doing for us.
No, I appreciate it, and having the partnership with the Dean's office, both with you and Dr. Bennett and Dr. Diller, to basically, tackle some of these difficult problems. They escalate every year, which has probably been the most surprising part of this job. But we have a great committee. We have great student representation. The faculty are phenomenal, and it makes what is otherwise challenging work, I won't say simpler, but understanding the legal and ethical ramifications of this work with students' careers and finances on the line is it's got a lot of gravity to it. So it's been very rewarding work, and I feel honored to be supported as much as we are from the college.
And this is really important because this is a way, and it's a difficult balance, as Bill said, because it's partly policing the profession and making sure that if there are truly bad actors and things like that, and sometimes that does happen, unfortunately, that we appropriately take care of that. But at the same time, it's a learning environment, and how can we educate people and not always discipline people, for things that we do. And there are things that come up, ranging from HIPAA violations, where somebody accesses charts, and those are legal issues that, we have to deal with appropriately, to, other more serious issues of unprofessionalism, lying, cheating, different things like that actually do come up at times that Bill and his group have to deal with, and, and create that good balance of, what is, the learning environment, how do we educate people versus where do we also then have to hold people accountable and discipline people. So it's a tough balance, and Bill has been very, very good at helping to manage that process.
I appreciate that. I can say that work on a hospital credentials committee gives great overlap into, I think, the obligation that we have as physicians, not just, like Andy said, to police our profession, but to make sure that we are putting forward not just the best physicians, but also the best candidates for physicians. And that it is really hard to weed a bad actor out of a medical staff, whether it be clinically, behaviorally, professionally, whatever the case may be. And if we start seeing patterns of that in the medical school, I can say the goal is not necessarily to get rid of them or expel them, but to hopefully identify that early for rehabilitation, because it's a big investment on our behalf as the profession, but also the school, and then their financial investment as well. And I think that's the approach that we have taken and has been mirrored by Dr. Falak's leadership, along with Dr. Diller and Dr. Bennett.
And so the classic article that was written that documented that students who have problems in medical school tend to be, students at a higher risk for having problems with licensure and things like that down the road, was actually written by a UC College of Medicine graduate. I'm blocking her name right now to do that, but it's probably 20 years old at this point in time. But it was a UC College of Medicine graduate did that research. I think she's at UCSF, San Francisco. But that's the power of the College of Medicine, of producing great graduates who are doing good things in different ways that you don't always know about. But that was a seminal work that really helped change the culture that we, if we identify these people early on and work with them, one, we can help hopefully prevent them from having problems, or if they really have the problems, to not let them get to the point where they might be doing patient harm and doing things like that. So another great UC College of Medicine graduate doing great work.
Thanks, Bill. That's fantastic. Any last minute questions for Dean Falak before we let him off the hook?
Well,
Dr.
thanks you all.
Gigolos.
Appreciate it.
Oh, Andy, we got
Just-
one more question. Heather?
Oh. Does someone have a question?
Yeah, I just had a question. I know how important health, wellness, self-care is to people in this profession, even pre-COVID. What is the college doing differently or from an innovative standpoint to help students, faculty, and staff deal with the pressures of the pandemic and everything else going on in our world with social injustice issues, et cetera?
Yeah, thanks, Heather. That's a great and significant issue. We have one of our faculty physicians, Jennifer Milano, who is in the Department of Neurology, is actually leading our wellness committee that's looking at some of the things that are going on overall. And Miles Pinzek, who's chair of our faculty practice plan, is on a weekly basis sending out some guidance and some activities. We have our Department of Psychiatry led by Melissa Del Bello and with one of our clinical psychologists, Barbara Walker, has really stepped up. And they have put on for our faculty some wellness groups, some small group discussions where people can join in to do that, not full-blown therapy sessions, but support type things along those lines, as well as making themselves available for faculty and staff who are distressed like that. So we're trying to ramp those up and looking at putting those programs. I think I would say that our gratitude award program is one of those of recognizing good behaviors and things. That's part of the wellness and the recognition to do that. And on the medical student side, Sean Cotton in integrative medicine, some others have put together caring communities of small groups for students. And that has been actually a novel and innovative approach of support for wellness for the students. So a major initiative that Student Affairs working with integrative medicine has put on, and they recruited faculty for these groups and trained them, and they have those groups going on to support the students. So we're trying to do things. We're looking for additional ideas if people have other ideas, but that is a real big issue. The staff at the hospital, right now, and this will be a segue into Dustin, but one of the things you worry about with the pandemic and what's going on is we may have enough physicians, but it's the staff, the ICU nurses staff and the things like that. Got a really nice yesterday. Yesterday, Miles sent around to all the UC physicians group the poem that was read at the inauguration yesterday by Amanda, and I can't remember her last name, which is but it was actually just beautiful and wonderful. And if you haven't had a chance to read it or listen to it, I suggest that you do that. And one of our faculty members who actually had been in New York in the spring and is now in the faculty here, just wrote back of how important and meaningful that was to her because of what she had done. She had a bad day. Here there's some deaths. We have the COVID issues and the things like that. And then she saw the poem and she read it, and it gave her a sense of hope. So just little things like that of sharing some of those positive messages and that sense of hope is really, really important because our faculty and staff can get burned out too with that. So Heather, thank you for bringing that issue up. It's a real important one that we really all need to really pay attention to and look out for one another and help one another in every way that we can.
Completely agree. I think compassion fatigue and secondary trauma is, going to be one of the big things with morbidity with this pandemic, and where I think we're all experiencing it. So, Andy, thank you as always. I know that your door is always open, and feel free to reach out to Andy between now and our next meeting if anyone has questions, comments, concerns, needs information. He's always happy to speak with us. So, thank you again. All right, so it's now my pleasure to introduce Dustin Calhoun. Dr. Calhoun is an associate professor in the Department of Emergency Medicine and he's also the Associate Director for the Division of Emergency Medical Services here at UC. And among his many clinical and administrative responsibilities, Dustin is leading the charge for the COVID vaccine distribution at the college and at UC Health. So, Dustin, glad you could join us and looking forward to an update.
Oh, absolutely. Thanks. I hope you can see my screen there. I'm trying to do a funny thing with using my tablet and my computer at the same time because one doesn't do PowerPoint and the other one doesn't have a camera.
Nope, we can see him fine.
And I also apologize for the outfit. I have fire department meetings all day today, so you're stuck with the uniform. So I want to go through, mostly I want to give people a chance to get the information they need and the questions that they have answered. But I would like to run through a few things just to ensure that some basic information, some updates that not everybody may have just regular access to. So just a little bit of an update as far as the state of COVID, and most of my information, I've narrowed it to Region 6, which is sort of what a lot of folks will call Southwest Ohio. Region 6 does not include Dayton, so this is sort of this area right around Cincinnati, going all the way out to like Adams County, Highland County, those kind of places, but does not go all the way up to Dayton. So if you look at this, it gives you just a bit of an idea of the 7-day moving average. We've moved to using 7-day moving average as a large portion of the data that we look at, and you can kind of see where we are with that related to hospital admissions, so the patients that are in the hospital, whether they're suspected or positive. And then over to the right of the screen, a little bit of information there about the percentage of hospitalized patients who have COVID, who actually have a positive test. And again, this is 7-day moving average. And you can see a little bit of a progressive increase and then stabilization and now a tiny decline. And then the ICU percentage there has been relatively stable throughout, which somewhat makes sense. This is similar data. This is specifically COVID positive patients in, so regardless of where they are, and not on average, this is just the specific number that are there on a given day. So you can see where we had that massive increase there around the end of October, beginning of November. And fortunately have not seen what many of us feared, which was a massive effect from the 2 back-to-back holidays combined with a lot of indoor time. So we have managed stabilization to some degree there. This just gives you a little bit of comparison of how our hospitals, specifically University of Cincinnati Medical Center and Westchester Hospital, compare to some of the others in the region. And again, this is just the number of positive patients within the hospital at any given time. So you can see that we have been amongst the busiest and show similar trends to other hospitals. Some parts of this are somewhat inexplicable. We have not been able to figure out why the actual pattern doesn't fit. If you look at Christ Hospital's pattern and Mercy Health's Fairfield Hospital, their patterns are somewhat different than ours are. And no one has really been able to put a good finger on exactly why that is. This I find to be pretty interesting, and this has become a public-facing sort of thermometer type of metric, which just shows us current occupancy of all the beds in all the hospitals in the Southwest Ohio region, and marking those out by color. So green is sort of what most hospitals consider to be their normal working status. Now, we have not been at their normal working state since March or so, but this is the normal number of beds. Say if we this time last year, this is what we would have considered that normal number of beds in our region. These are with some moderate tinkering. This is when we start opening up beds that are reasonable clinical spaces, but they're not necessarily spaces we use all the time. It might be in some cases double occupancy of some spaces that are intended to be double occupancy but aren't normally double occupancy, and that exactly what measures are done with which systems depends. When we get into the red area here, we start talking about possibly using areas that are definitely not normally clinical areas, making some places that are not normally double occupancy as such. And then into the black is when we start doing things that we see on the news, things that we see that happened in New York that fortunately have not had to happen here. But this has been a useful metric to show the public sort of where our healthcare system is. And when we've coupled that with messaging that, it's really in their hands where we are on this. It's in their hands as to, doing the social distancing, wearing masks, those sorts of things, and now getting vaccinated. And it seems that this messaging really was what kicked in at the end of November, beginning of December. And I would like to think, though we have no proof of it, obviously, that this had some effect on curbing that rapid rise that we had there. So where are we as far as vaccinations? That's what everybody is interested in. This, as everyone has probably seen, is the CDC's vaccination phases. I put those up there mostly as a reference because unfortunately they have absolutely nothing to do with us. So this is sort of the breakdown of how the CDC outlined from the very beginning and didn't make massive changes to it as far as vaccination and who and what prioritization they think that we should be using. This is Ohio's phases, which are slightly different. More importantly, they're just not complete. So one of the unfortunate things that we've had with Ohio ODH so far, and I understand that they're dealing with a lot of complexity, is that the information is a little bit last minute at times. So who we're allowed to vaccinate, when we should be vaccinating them. The most recent has been who will be vaccinating this third group here, this group of the severe congenital and developmental disorders. And then there's actually more complex wording to that. And then who is going to be vaccinating these groups. And this is something that will be starting next week. But it's still a little bit unclear, even as of today, who is responsible for that. And I'm not making a joke at all when I say that I've had multiple conversations this week that have involved phrases like, no, look where the comma is. This is what they actually meant. Because it very much requires a lot of interpretation to figure out some of the wording that's provided. And because they are as busy or busier than we are, getting answers back from them can be kind of difficult as well. So that's what we're working with. Our ultimate goal is to vaccinate as many people as we can, but trying to get those in the right groups as much as possible. Some very interesting data that that looks at, and I apologize for not putting it in here, but the fact that the age group is the most closely tied to effect of vaccine, meaning that as you go up by decade, the number of vaccinations you have to put into that population rapidly declines, or the number of vaccines you have to put into that population to save one life rapidly declines. And that's pretty common sense, but it is to us as healthcare providers. To the general public, it isn't. So the fact that Ohio has been shifting itself more toward an age-based distribution actually simplifies things logistically and operationally for us, but we also like the idea based on actual science. It does seem to have some benefit. So that is where they're aiming us right now. We as healthcare systems are getting the message that that's going to be our part of this process. We are to vaccinate the age-based populations. Like right now, the only people we are vaccinating other than second doses, the only first doses we're doing are people 80 years and older. It is our understanding right now that next week we will be vaccinating people 75 years and older, and the more complex, the severe congenital developmental disorders, and then this litany of other disorders that right now are an and modifier, meaning you have to have the severe congenital and developmental disorder or developmental disorders and one of these other things this week. Those are being handled by the health departments, and it sounds like now by Children's. It sounds like Children's is working with the health department to get those. It's a fairly small number that, from what we can tell, is being determined by a board to narrow those. We don't have information as far as how the K through 12 will be handled when that is opened in a week or two. But we're slowly getting there. The information that we have, we take and work toward vaccinating that population. And so far, we haven't gotten to a place where we didn't have anyone to vaccinate. So we were standing around asking who else we can vaccinate, which we don't foresee happening, obviously, for any near future. Before we got to here, we were actually vaccinating healthcare workers. So we started that in the middle of December, as most of you know. We have given out 9,157 first doses and 1,643 second doses. Our second dose process is ongoing. So this number will eventually, we hope, near match with the first doses, or possibly exceed it, because we've actually given second doses to a few people that others have given first doses to. Some interesting facts that are useful to know that I like to point out is we have wasted not a single dose. So there has not been a single dose that has been accidentally done something with, been left out too long, not been able to find somebody. So we're very proud of that. We also have vaccinated more people than we received doses. which seems mathematically impossible, but most of you have probably heard about the overfilled doses. So with the Pfizer vaccine, we're getting on average 6 or 7 doses out of a 5-dose vial. And with the Moderna vaccine, we occasionally get 11 or 12, but most often they are closer to 10. Partially, we've done that by being very conscious of what equipment we're using. It actually makes an enormous difference which particular needles are being used for this process. Some needles just have greater dead space in the hub portion than others, even if they're the same gauge. And then who's doing it? We have purely restricted the draw-up process to our pharmacists. So a limited number of people who are doing an excellent and very precise job of it. And that has allowed us to vaccinate a fairly significantly increased number of people above the vaccines we've actually received. So this process will continue. There is a little bit of question, or not a little, there's a lot of question right now as to who will continue doing first doses. Because as you know, there were a number of providers who did what they should have. They followed guidance. And guidance was that if you have been ill with COVID within the past 90 days, you shouldn't get vaccinated. You should wait. Now, part of that's a public health effort of trying to spread out the vaccine as much as possible and get the most people protected as possible. Since we all believe that, or most of us believe that you're pretty well protected in that 90-day period. Part of it, though, was the potential for decreased efficacy of the vaccine during that period. Well, if you were sick at the beginning of December, then you have yet to have an opportunity as a 1A healthcare provider to get vaccinated. But then we've been given the direction as of the last couple of days that healthcare systems are no longer allowed to give out 1A vaccine. And that process now has to move entirely to the local health departments while we move on to the 80 plus group. So we're working on sorting through that because we will have a number of providers who haven't had the opportunity yet, and then new hires that will need it, or people that change their mind. We don't want to penalize them for that either. So we're working through that. We don't have answers to that yet. Thus far, we are allowed to continue giving all of our second doses. And the one big kudo that I have to give to all the agencies involved in this is from the very day one, we have been thoroughly assured that we will receive 1 second dose for every single first dose we were given. So we've never had to worry about organizing that too much. We've never had to worry about holding back any doses. They were very clear and they have stood by that. So we do anticipate continuing to do those specialized clinics. Moving to the public side of the vaccination with the 80-year-olds, we right now are running 1 location for that because it does take an enormous amount of effort to get these things up. We're doing a drive-through through the UCG&I garage. So we were given both decks, P1 and P2 of the UCG&I garage, which if you've never been in there is the nicest garage that I've ever been in. It's specially designed for neuro patients, so it's a flat floor, which makes it very good for people standing on it all day. It's also extremely well lit for the neuro patients. It's also fully enclosed, which is the most important thing. It keeps us relatively warm in there, and then we have received the funding necessary to put in permanent electric heaters above the primary workstation, so we can do a drive-through. There are a lot of logistics to putting in a drive-through in the Midwest in the winter, but we've done that. We're on our 3rd day or 4th day today, if you include our test run that we did on Sunday, which actually did flow vaccine. So that's working well. We anticipate that being able to, at peak, do 1,000 to 1,200 people per day in a 12-hour shift through there. So 80 to 100 people per hour. Once we have this well underhand, our plan is to move likely to the exact order of this is not entirely determined yet, but likely to a Westchester centered location. We don't know yet. We haven't decided yet whether that will be actually out of a UC Health Westchester campus building or partnering with a local school. We've talked to Lakota East and they've been extremely cooperative. That would be a walk-up location. And then likely after that, the Daniel Drake location, which uses their cafeteria, which will also be a walk-up location. We just felt it was most important to get a drive-through going early for this elderly population who do better as far as not having to get out of their vehicle. But it's been a great success. I don't know the exact number that we've done through here because they've been doing it while I was on this meeting. So I anticipate that we've done right around 1,000 so far. Our narrowing point right now is getting people on the schedule. Doing this as a public health effort where you're basically just putting things on minimal charting is actually much simpler than doing it as a health system where you're doing standard charting through your standard medical record. So getting them registered, getting them appointments, things like that has been tricky, but we're getting there, and that is rapidly speeding up. Each day we're doing a slightly larger portion, but we anticipate getting to that goal of 1,000 to 1,200 or so at that single location per day. But we are working through that. It does take some time. Many people ask the question of, well, why do you do appointments, or why do you do the medical record? Well, the medical record is just required when you do it through the health system. The appointments are necessary for just simply crowd control. If you just open it up on Clifton campus, we would have massive problems with traffic and social distancing. So we are doing it through appointments, but we don't think the appointments themselves are actually the problem. It's really the getting people into the computers. The 80-year-old crowd obviously adds a complexity there too, because they're not the most MyChart user group in the population. We anticipate the younger the crowd gets, the more we will be able to do e-check-in and electronic registration and those sort of things. So that's where we are with that. These are just a few pictures from our trial run that we did the other day. Our process essentially works where you come in the front door of the garage, you circle through getting registered, then getting education. You can see in this screen here, we have several TVs set throughout with a video that was produced by our pharmacy group and our marketing and communication group. We also have it actually playing out through the radio, so you can tune your radio to 98.9 and listen to the education as you ride through. So you can see it. This has captioning there in case hearing limitations. You can also just listen through your radio, and then rolling through, getting to the site where you get vaccinated while sitting in your vehicle. We can vaccinate anybody that's in the vehicle. We haven't had 5 in a vehicle yet, so I'm not sure where that middle person may have to actually get out of the vehicle. Getting people to dress appropriately to where we can get to their shoulder has been an interesting trick. And I do have to say, not criticizing, but I do have to say that spending the last 3 days in a concrete structure with 80-year-olds in cars has been interesting. Because you would be shocked at how many of the 80-year-olds are driving themselves, and many of them do an excellent job. Some of them don't. We have not had anyone injured. We have had a couple of yellow poles struck, but only minimal damage to the vehicles, and have not had any major problems from that so far. So that's where we are. Very brief overview. I'm happy to answer any questions. I know I went through that pretty quickly, but I just want to make sure that everybody can get the information that they want rather than just what I want to put out there.
Dustin, thank you so much. Quick question for you on the drive-thrus. Are they then having them sit for 15 minutes in their cars while they're observing?
Yes, that's one of the beautiful things about that garage is that we do all of the things I mentioned on deck 1, P1, and then they go down a ramp to the lower level where we have ACLS certified providers and a code cart. They sit there. They actually, while they're there, they schedule their second dose appointment. So kind of like going to the dentist where they force you to have an appointment when you leave to guarantee you come back. We get them an appointment before they leave. By the end of that, they're usually pretty close to their 15 minutes, and then they're allowed to leave.
That's great. You know, as a pediatrician, pediatricians have been doing this for years with flu vaccines and drive-through clinics. So it's really neat to kind of see the adult population sort of pick that up. Dr. Weicker raised her hand. Ann, you want to unmute, and the floor is yours.
Hi, just a quick question. So the 80-year-olds that you have coming through are people who are in the system through UC Health?
No, we are the only system in the region who is open to anyone. Everyone else is restricted. As far as we know, I don't want to misspeak and guarantee that I'm right there, but as far as we know, we're the only system who is not requiring you to be a system patient. Now, it's interesting because that's actually a direct requirement by the state. It's actually in writing. You are not allowed to limit yourself to only your patients if you're getting state-funded vaccine, which is the only kind of vaccine there is. We are allowing anyone to do through the electronic record system. Yes, you would have to be a UC Health patient. But if you're not a UC Health patient, you pick up the phone, 513-584-DOSE, and that gets you through to a line where we can register you. Right now, our average wait time is only about 6 to 12 minutes as of yesterday afternoon. Yesterday morning, it was higher. We've added people to it. So moving pretty quickly through there. If you are a UC Health patient who meets criteria, which this week is you are one of our patients, and we define that since ambulatory typically defines current patient as somebody within the past 3 years. So past 3 years and over 80 years old and with an active MyChart account, you got a push notification that said, hey, we can vaccinate you. If you click here, we'll take you to a scheduling thing. And then the scheduling thing pulls up, you click the time you want, and you're done after hitting submit, I think. So it's very simple if you have MyChart, and we've been pushing out messaging that if you are a patient but don't have MyChart, it's simple. Please get MyChart. That'll make your life easier. But anybody can call the dose line if they want to.
Thank you very much.
Pat, go ahead. Pat, you're muted.
Yeah.
There you
Sorry.
go.
And I'm getting an echo. Never mind. Let's fix that.
There we go. I'm having technical problems too. Well, Pat, while you're typing, John, you had a question.
A couple, a nice very nice presentation, Dustin. This is a tough topic. A couple of questions on the Pfizer. Are you running into any logistical problems with the refrigeration on the Pfizer?
No, fortunately, we have. I mean, it's obviously a little more complex with -70 versus I think it's -20, but it has not been a problem. Our pharmacist, and that's one of the beauties of having pharmacy having taken lead on this. They have not had a problem with it. Very careful, obviously, with when we thaw it, making sure we never put too much out there to where we can't use it up in the right period of time. Careful as to when we puncture vials and those sort of things. But no, it has not been a problem for us at all.
Second question, how are you tracking potential, I guess, intermediate adverse reactions? So not the anaphylaxis, but I don't know how we're going to follow folks like for the next 3, 5, 7 days after they, how we're going to track different reactions.
So we're giving out the information that the state has recommended, which is the VSafe app. So we're giving that out, recommending to patients. Now, you can imagine that 80-year-olds who didn't use MyCharts probably aren't adding a whole lot of apps to their phone either. So we don't know the success of that. Obviously, we recommend to people that any questions or concerns or problems they have, reaching out to their primary care doctor. Part of the education we give them is warnings about various side effects and that they should reach out and let a healthcare professional know. So we've been trying to cover all of our bases as best as the situation allows.
And then the final question is, what's on the horizon as far as the adenovirus vaccines, and are they going to be coming online soon?
I don't know. I know that they are up for approval soon. I'm actually more scared of that than happy, because we have enough people as it is who, for whatever non-scientifically based reason, prefer Pfizer versus Moderna or Moderna versus Pfizer, and their numbers are almost identical. So once we have the Oxford vaccine out there, I have no idea. This is the only thing I lose sleep at night about, is I don't know how we're going to deal with that. And we're trying to figure that out. When you have a vaccine that has like 60 to 70% efficacy, if you dose it the way they intended, or if you half dose the first dose and full dose the second dose, then you get maybe 90%, but only on a young population. We don't know how to deal with that information. And more importantly, we don't know how to, because right now we're not giving people a choice. We either have Pfizer today or we have Moderna today, and that's what we're given, and that's what we give out. I don't know how we deal with scheduling or patient preferences when there actually is science that says one is better than the other.
Thanks for the update.
Yeah, that's really interesting, John. We deal with that in pediatrics. Obviously, there's different, makers of vaccines versus, do we use GSK's DTP? Do we use, with other things? So that's a really interesting question. Dustin, Pat Biter had asked a question wondering sort of volume. How many doses for 80-year-olds did UC receive? Do you have a number?
Yes. So we only received 975 doses for 80-year-olds. And that was 975, I believe, of Pfizer, because Pfizer's the one that comes in 975. But we had, because of the way the state some strange things with shipment. Basically, they asked us how many more doses we could use on healthcare providers. We told them the full number, which was a fairly substantial number, expecting that we would get that incrementally, kind of like we had been getting. over a period of time. Well, we got all of that all of a sudden at one time, and then a couple of days later, they said, hey, you're not allowed to give it to 1A people anymore. So we've actually rolled what we had left there into, and I can't remember the exact number, we've rolled some of that in. So we have more than 975. So right now, we're actually in a good position to be able to vaccinate essentially anyone in that age group that comes to us.
Great. And then Pat had a follow-up question. Does the Janssen and Johnson & Johnson vaccine, since it's only one dose, scare you a little less?
That one, yeah, because there's sort of the trade-off, at least there, with the single dose making logistics much easier. You take the second dose out of it. There is some advantage. Some people will want it purely because of that and willing to take a little bit of different numbers for that trade-off, for sure.
Great. Well, Dustin, thank you so much. I really appreciate that. Was a fantastic, very informative on both sort of the volume and hopefully, with the vaccine, it looks, numbers look like they are slowly trending down. Hopefully that will continue. And we appreciate all that you're doing to get the vaccine out there. So thank you very much. And thanks for spending some time with us.
Absolutely. Thank you very much for giving me the time to present.
Take care.
You too.
All right. Well, we're going to go ahead and move on now. And I'm going to introduce two of our fantastic fourth-year medical students, both of whom I had the pleasure of working with during their PEDS rotation. And we just wanted to sort of invite them, as Andy kind of teased, obviously this is a year unlike any other, at least last year. The fourth years did get to complete their residency interviews in person before the shutdown and the quarantines hit. So I wanted to introduce Sage Kamara, who is interviewing in pediatrics, and Jasmine Prince, who's interviewing in internal medicine. Even though I tried to get her to do med ped, she's stuck with internal medicine. And just to kind of give a perspective on sort of their experience, they're probably about done wrapping up interviews and getting ready to put their match list in. And guys, the floor is yours, and just kind of sharing with some of the alums sort of what that journey's been like and what you guys are up to.
Sounds good. Thank you so much for introducing us. As Dr. Peltier said, my name is Sage Kamara, and I'm a fourth year applying into pediatrics, and I just finished my virtual interview trail last week. And so I think what was really scary when we heard things were virtual is they came out with all of these new webinars and like how to virtually interview, and every single webinar had a different piece of advice. Like some said wear headphones, some said absolutely don't wear headphones. There was so much emphasis on what was your background going to look like and what was the lighting. And so there was so much fear in figuring out how was I going to make sure that setup was correct when everyone said something different, and this had never been done before. But I will say now that I'm on the other side of things, it went better than I expected. There was a lot less technical issues than I ever imagined. I was able to complete all of my interviews. There weren't any times that I had to call them instead of doing it via video. The biggest variability in the interviews was length of the day and how they structured the day. Every program did it a little bit differently. I would say on average, my interviews were 4 hours, consisted of an overview session or a Q&A session, and then 2 to 3, generally 30-minute interviews. So a lot of the days were shorter than I think they would have been in person. And I would say the biggest con for me was there's many cities on my list that I've never been to, and I still don't have a good idea of what the city is like. Now, if I'd been there for 24 hours just to interview and then leave, how much of an idea would I have? But at least I could say I'd been there. And then I got a better sense of the program's culture than I thought I would virtually, but I still don't know if it's as robust as if I had been there in person, seeing people really genuinely interact versus interact over Zoom. So overall, better than expected, but still I think definitely some room for improvement. And I'll be very curious to see what happens next year, because I've heard there's some talk of continuing it to be virtual or a hybrid nature.
Well, which makes sense. Obviously, one of the plus sides is that you guys didn't have to have the expenses of traveling, right? And hotels and all of that. So there are definitely some advantages of that. Jasmine, what's your experience been like?
Yeah, thank you for having me. My name is Jasmine Prince, and I'm a fourth year. I'm applying to internal medicine. I would echo a lot of the same things that Sage said and the fears that we had going into it. And I would also echo that it wasn't as scary as I think we all anticipated it to be. I think one of the things for me that was kind of nice was that I was able to go to all of the interviews that I was invited to and do them in a schedule. I actually finished all my interviews before Christmas. And so I was doing 2 to 3 interviews a week for about 6 weeks. And I was able to do those like cities that weren't in the same place that I couldn't have done 2 to 3 interviews in the same week. So I think that was a plus. Scheduling was a lot easier. I think people were able to apply to more places and take more interviews, but I think will be interesting to see how the match actually goes because people were able to kind of hoard interviews. I think the only thing that I really missed out on the interview day was I think the schedule was similar to what Sage said. Some were like 8-hour days, some were like 2 or 3. One plus was that a lot of the content that you would get in a typical interview day where you're just sitting and having someone tell you about the program, a lot of programs recorded those on videos and then uploaded them to their website. So you're able to watch those beforehand, which is actually really nice because then you get all of this information and then it all jumbles through the programs. And so you're able to go back and have those resources, which I think has been really nice as you're trying to make sense of all of the information you've been given. And then it makes for shorter days. I think the actual interviews are just as they would be in person. You're just sitting and talking to a person. The resident meet and greets, most places tried to do like a night before kind of social hour, which was nice. It gave you a little bit of the vibe of the program. I think you miss those one-on-one conversations because like if you're sitting at a table with someone, you can turn to someone next to you and there can be 10 conversations going on at a table. And on a Zoom platform, you just can't do that. So that's the kind of thing I think that you just really can't simulate.
Well, and you also don't have to deal with weather, right? So that's the other issue. So can I just ask you guys, one of the things that I think I've been really sort of shocked as I've been doing medical education in my career is the number of programs that you all now apply to and interview to. So, Jasmine, you had said you actually think you may have done more. How many, can I ask you each, how many interviews did you guys actually do?
Yeah, I applied. So the recommendation for internal medicine is to apply to like 18 to 20 places, or this is what my advisor told me. Apply to 18 to 20 places, interview at 10 to 12. Okay. I applied to 20 programs, and then I got offered 17 interviews, and I did 16 of them, which I typically probably wouldn't have traveled to 16 different places. So I was able to do a few more than I probably would have.
And then I applied to 26 places. The recommendation was like 20 to 25. When things went virtual, I was told a little bit on the higher end. And then I ended up doing 16 interviews. And I think if I had been, like Jasmine said, just due to scheduling, I probably would have been more around like 13 or so if I hadn't done it virtually. And that was kind of the recommendation prior to interviews becoming virtual.
What did the programs do anything as far as, so Pat Biter, whose wife Libby is one of the faculty here in family medicine, had made a comment, and I think I told you guys this too, right? So program directors are just as freaked out as you are, right? This is new to them too. And one of the big concerns that I think a lot of program directors have, especially, I'll speak as a pediatrician, obviously Cincinnati Children's nationally known, but many people, especially East Coast, West Coast, may not be thrilled or, have favorable things about coming to Cincinnati. So how did programs sort of present cities to you? Did they, have a video presentation? What was sort of that experience like on the city? Not so much the program, but the city.
I think it was more just me asking people what they like to do in the city. It was something I tended to just ask during interviews in places I had never been. A couple of programs would kind of highlight some like fun restaurants to eat at or things to do, but I really feel like that was one of the big things that was lacking, at least for me in a lot of my interviews, was about learning about the city, and just a little bit harder to do virtually.
Yeah, I felt like most places actually, I feel like in most of my interviews, they had a PowerPoint that was kind of highlighting the kind of food, things to do, hiking, bike path, like if people have a car in the city, if they don't, those kind of things, transportation. And then some places sent like a little care package with different like things highlighting their city, which was kind of nice too. Things that they would like typically give you during their interview day.
Nice. All right, well, guys, I'm going to go ahead and open it up to our council for questions that they may have. Feel free to raise your hand. Dr. Wojciechowski, the floor is yours.
Hi there. Good morning, everybody. Paul Wojciechowski actually worked for the College of Medicine. I'm the anesthesiology program director. So I'm really happy to hear that our two students had a pretty positive experience. can tell you from the program director side, we really, we did stress about it a lot. I think just as much, maybe if not more than the students did. In general, the experience was pretty positive. We actually had a good overall turnout for our interviews. We had fewer cancellations. There definitely was some advantages, but I think from, purely from my perspective, I will look forward to a hybrid model in the future. And because I think some of the things that, especially for Cincinnati, if we're talking about our college and our medical center, that I wanted people to see, it was very hard to actually have them see and have them experience. So bringing folks to Cincinnati, I think, is a good thing in the whole process.
Paul, did you find that did your residency interview, the students said they actually probably applied and interviewed to more. Did you find that you interviewed more medical students this cycle?
Yeah, a great question. We actually did. So we added an additional interview day and interviewed 12 more folks than we normally would have. And so we did open things up a little bit more. Our pool of qualified persons was huge. And so we could have interviewed and kept interviewing, but at some point you unfortunately have to just say enough. But we had a great pool of candidates.
Nice. John.
Okay, ladies, during your process of interviewing, were you able to talk to active members of the residency programs during the interview process?
Yeah, for sure. We had, I think every single interview I did the night before had an hour-long kind of Zoom session with the house staff. And then usually there was segments during the day where there was like breakout rooms, and the chief residents and some of the residents would kind of be in this like main room throughout the day so you could ask questions. There was always someone like monitoring the chat. So if you had questions, people would always monitor that. If anything, we maybe had more access to the residents just because they were like present on the Zoom all day, whereas maybe they wouldn't be in the room during the interview. But yeah, I definitely feel like we got maybe not the one-on-one conversation, but you were able to ask your questions completely.
Excellent.
Yeah, I had a similar experience to Jasmine. We had a social for every interview that I went to. And it was interesting. There was so much variability in the social events. One program had me I was like a little person, and I walked around a room and could switch conversations, which in theory sounded really great, but it was very awkward to like leave these group conversations, and I actually preferred Zoom rooms. But one thing that I found really helpful, one program, they had all their residents in pods for the whole interview season. And so they were all together eating dinner, and I really got a sense of like how they got along with each other, how they interacted versus them all being individually talking to me. And then all of my programs either had a session with residents during the actual interview day or a one-on-one interview with a resident to be able to ask them questions.
Nice.
Great. Thanks, John. Did any of the programs that you guys, either in peds or internal medicine, did they have like a formal second look session or, a follow-up session?
I have a few scheduled in this month and next month. And then there was also a lot of diversity efforts that I was a part of this year that I don't know that speaking to people who've interviewed in internal medicine in past years, a lot of the programs that are doing it this year weren't doing it in previous years. I don't know if that's because of the virtual format or because of kind of the social platforms that have been in the forefront this year, but I've gone to a lot of those, and they're actually usually through all of the departments in the hospital. So that's been kind of cool to meet other applicants and residents from other departments.
Yeah, I've only had one second look event that I have had, but there have been a lot of talk about if you want to come to a morning report or a noon conference or grand rounds and more opportunities to do other things virtually that I think weren't there in the present or in the past. And then also, like, if you want to talk to a faculty member, a lot of like opportunities to reach back out if you wanted to meet with someone again over video chat, but haven't had very many second looks.
Great. Well, guys, thank you so much for taking a little bit out of your clinical time. Sage, tell Dr. Shaw thank you very much. And I will talk to you guys soon. Thank you so much. Good luck with everyone. When's match list due?
March 3rd, I think.
Yeah, we have to certify on the 3rd.
All right. Well, good luck. We look forward to hearing where you all match. So
thank you.
Thank
all right.
you.
Take care, guys. All right. Well, I'm going to turn it over to Kim and Mary Jo and Gabe, but before I do that, they're going to give a development and alumni relations update. But I'm not sure if they were going to mention this. I'm going to steal a little bit of somebody's thunder. But thank you to all of you that participated in November for Giving Tuesday. It was a very successful campaign. I don't have final College of Medicine numbers, but I know we were able to raise $18,000 for the Ivy Dean Scholarship, which was fantastic. I think Katie had told me that I think that was the second most dollars raised. So thank you for all of you that donated and reached out and donated. And I'll turn it over to Kim and Gabe and Mary Jo.
Excuse me. MJ, do you want to start?
Yeah, sure. I just wanted to update folks on a few things here. First off is our Distinguished Alumni selection. That process is going on right now. We are going to extend it because we are putting reunion, moving it from the spring to fall of 2021. So we'll have a little bit more wiggle room with it being able to get nominations in for the Distinguished Alumni. Some of the community members are on today. We had moved the selection committee to February. I'm going to again send you another update on that because we'll be moving that to after our meeting on April 22nd to make those selections. And again, in hopes that we can get the word out and bring in quality nominations for our Distinguished Alumni for the classes ending in 1 and 6. So that's first. And on the reunion piece, again, I just want to reiterate, we are moving it from the spring to a hopefully live and in-person reunion in fall of 2021, and it'll be over the homecoming weekend. That date hasn't been announced yet. We're waiting for the university to set that date, and we'll make that available to everyone as soon as that is. And we'll play it by ear and see how things are. At this reunion, we're going to celebrate the 1s and 6s. It's their reunion. And we will also celebrate the 0s and 5s that were canceled. So it's going to be a big time for all those classes to be able to get together. The Distinguished Alumni from all of those classes will also be honored at the fall reunion. It might look a little different since it's centered around the fall and homecoming, so we'll look forward to maybe shaking it up a bit and doing some fun and different things for our reunion while staying true to our class parties and some of the things that have been so meaningful to our returning alumni. We also are in the process of just kind of giving a placeholder to our 0s and 5s again that were canceled because quite honestly, it'll be a year and a half by the time they get to come back. So we are putting together a website just for those classes that will consist of a lot of information about the college, tours to view virtually of the college. But I think the biggest thing about this website is it will have sections for each of these classes. So you go to the website and you can find your class of 1995 there, and you click on your class composite, and then you can read about all of your classmates that turned in information about their reunion, you know, just where they are in their lives now and so forth. So catch up on folks. Look at pictures from previous reunions and pictures that were shared that were going to be shared over reunion, but that was canceled. And then also some popular culture things that are going on. In addition to that, there'll be a way to connect with your classmates through a special Facebook page. So that'll be designed just for your class. So you can make those connections offline with each other without having to worry about trying to get contact information and all that. You can get that with each other through this site. So that's just a quick overview of this website. And again, it's in the process of being built. It's due to launch on March 18th. And we will have a party to launch that. So thank you, Jeff Taylor, for connecting us with Dr. Shumrick who led up the Otolaryngology department. His son owns a winery in Northern California, and they are going to partner with us, and we'll do a wine tasting with this winery with our zeros and fives, and have some fun with that. And then we will also have individual classrooms where you can go and catch up with each other after the wine tasting. The wine tasting, again, it's just a fun way. It's not a serious, really good wine, by the way. You can look them up. It's Tobin James Cellars. Is a winery, and there's a special alumni kit that has been prepared for this. And you will receive an email about this event, so you can register for it. Of course, it's free, but the wine isn't. So they will take your order and they will ship that directly to your home. And then another thing that we have going on briefly is we're working on starting a new program called Chats with MedCats. And so this program will be more of a small group program where we have one of our MedCats who specializes in a particular area that will that will speak to a small group and just have a nice one-on-one conversation about a particular topic. If there's a topic that you feel would be a good fit for this, please email me. I would love to explore all our different available folks out there that could be a good fit for one of these Chats with MedCats programs. All right, I'm done. Any questions? Questions for you?
MJ, do you want to mention the Uncorked event next month?
Sure. So next month on February 11th, we have joined forces with the UC Alumni Association, their Uncorked event, and there's a wine tasting for that also. Dr. Rubenstein, that is a cardiologist with UC, and also an associate professor, is just going to give like a very short little lighthearted update on the facts and fictions of wine. And then it goes into the wine tasting. So it's just a fun little spin on their Uncorked event, their tasting event. And those, you will get an email. You may have already gotten the email. I think it went out this morning. I took the zeros and fives out, so I'll send you one.
Thank you. Yeah, so I think there's going to be, this is a group that normally they do in-person wine tastings. It's a group of UC alums. Obviously, they've been doing virtual for a while now, and I think they've partnered with a local shop that's going to have a couple of different wines as well as some chocolates, and just going to be kind of around Valentine's Day. So just a fun little thing. If you're interested in participating, please join us.
Yeah, and the basket, it's a couple bottles of wine and an appetizer also, and it's for two. So that can be purchased. You do pick it up at the facility. It's only a local event, and it's Z Place for Wine is who's hosting this wine tasting.
Kim?
Good. Just one thing I think that MJ forgot are the socks.
Oh, yeah.
We have some fabulous socks that everybody received. I hope you enjoy them. They're nice, they're warm, they're really sweet. So thank you for sending those out, MJ. That's really cool. A couple other things I wanted to mention. One of the things that the Alumni Association also did most recently was a presentation on the vaccines with Dr. Fichtenbaum. We had over 500 people register for that. So I think that, just a reminder of how important our Alumni Association is to the work that we're doing. And then in regards to Chats with MedCats, I saw the question in there. The idea behind that is really to have our alums talk to our alums. And that sort of leads into the two topics that I really wanted to touch base with right now. One of the things that has also been a little bit difficult during COVID is for us to actually potentially to talk to donors. Our national team, our Plan Giving team, and then our, and our GABE team here at the College of Medicine has done a lot of reaching out, a lot of quiet responses. So it's super important for us to be able to raise scholarship dollars. One of the priorities for the Next Now campaign is scholarship. As the students continue to have a lot of financial burden once they graduate, we really, really need that opportunity to have scholarships. So I just wanted to open it up for just a second to see if anybody had ideas, because I know the national team has been making calls. I know our Plan Giving team has been making calls. I know Gabe has. I know there's a lot of fatigue when it comes to everybody in regards to responding to these kind of things or doing a Zoom call, but any ideas that anybody has that might make it a little bit easier for our team? We have a reduction in our team too. So as trying to keep up with everything, we wanted to see if there's things that we could be doing differently that maybe would help us. Anybody thoughts on that? If one of our national team members or Plan Giving team's members would you respond? Would you email them back if they called? Is the timing weird? Anybody help here? Well, I mean, now you can see why it's been a little bit tough for us.
Yeah.
It's hard to get people to respond right now. Okay.
Email probably your safest bet.
I'm sorry.
He said email is the safest bet, is what Pat said.
Okay. The personal emails and phone calls that you get from Gabe, he's the best. He's absolutely the best. Okay, guys, I just would say if you get something from one of us, even if it's a little, hey, timing might not be great, can you respond? That would be really helpful. Gabe, did you want to add something? I see you flashing over there.
I wasn't going to add anything in particular on that piece. I just wanted to mention some of you may soon be receiving an invitation in regards to our upcoming College of Medicine scholarship reception. But for this group, I think anyone who would be interested in attending that, I would encourage you to let us know. You would get an invitation automatically if you have a scholarship that you've established at some point in your philanthropic relationship with the university, or if you've given over a certain threshold to funds like Ivadine or the Lucy Oxley Fund. But if you would like to attend, especially with this group, I don't think it's required, we would necessarily feel obligated that you meet any of those thresholds. Because of your role as important leaders for the College of Medicine, we would certainly welcome your attendance. You'll get to hear from Dean Filak as well as from one of our benefactors and one of our scholarship recipient students. This, of course, is happening virtually. Normally, we would have an in-person luncheon, but for this year, we're going to be hosting that on Friday, March 12th. It will be over the lunch hour, and you would have an opportunity to, after hearing from those individuals, get to interact one-on-one or in a small group with a student who is a scholarship recipient. So if you have an interest in attending that, feel free to reach out to me, and I can make sure that you receive that invitation so that you can register and attend, and we'd love to have you there.
Great. Thanks, Gabe. Guys, anything else from the development team? I have one item in new business I just wanted to share, and then we'll let everybody go. But anything else from MJ or Kim or Gabe?
The only thing I would say is that our reporting for the next meeting will be super robust if you respond to our emails and calls. Thanks, guys.
Great. Thanks for all your work that you do for the college and for scholarships. So I just have one, just a nice way to sort of end our meeting. MJ sent this to me, and I think he's still on the call. So one of our own, Dr. Jonathan Bernstein, who's a professor in internal medicine and immunology, allergy, and rheumatology, has been elected to the executive board of directors of the American Academy of Allergy, Asthma, and Immunology. He will serve this year as secretary-treasurer before becoming president-elect in 2022. Jonathan's from the class of 1985. He will lead the organization as president in 2023 and then serve the final year of his 4-year term as immediate past president in 2024. So if that's not cool enough, here's the really, really cool part, right? So Jonathan's father, Leonard Bernstein, class of 49, also professor in internal medicine and also a Daniel Drake Medal recipient in 1999, also served as president in 1982. And this is the first time that a father and son have served as president of this organization. So congratulations to Jonathan. Great representation for our alums in our College of Medicine. And on that, if anybody else has any further business, we've got a minute or two. If not, thank you for your time. Our next meeting is Thursday, April 22nd. My guess is we also will probably be virtual at that point. And you had raising your hand. Go right ahead. Oh, you're muted, Ann.
This just has to do with Dr. Leonard Bernstein. So I went I graduated from medical school in 72, and in, I guess it was probably 1970, he lectured our class about allergies. And so all my life up until that point, every summer, I just had a terrible time, mostly August, September, October, whatever, breathing. And they would load me up with this chlorotrimeton and I would have to go to bed. It was just terrible. And then I heard Dr. Bernstein talk, and he said, you know, I can give shots for this sort of thing. And oh my gosh, so I made an appointment and started the shots, and that ended that. It was just a miracle. So just to say how far things have come, and congratulations.
Definitely. Thanks, Ann.
Thank you.
All right. Well, guys, have a great rest of the week, and thanks for all you do for the college. And please, you know, again, to echo Kim's sort of plea, if you receive an email or a call from the team, please respond, and we will see you all in April.
Great. Thanks.
Take care, everybody.
Bye-bye.
Bye.